Hi, everyone. My name is Malie Coyne, and I'm a clinical psychologist. I'm your podcast host for today, for the Clinical Psychology Today podcast. And I'm absolutely delighted to have Dr. Sharon Lambert here with me from the School of Applied Psychology in UCC. Hi, Sharon.
Hi, Malie. How are you?
Great to
Thanks
have
for
you.
having me.
I just thought it would be really fascinating to interview Sharon about her work in applied psychology and her views on trauma-informed practice. I'm just going to give you a little bit of a bio on Sharon. She joined the teaching staff in the School of Applied Psychology in 2014, following a number of years working within community-based settings that provided supports to marginalized groups. Her research interests involve primarily around the impact of trauma on development, its link with substance dependence and mental health, and consequent considerations for service design and delivery. And Sharon conducts research with community-based partners such as addiction, homelessness, criminal justice, and education organizations. And the research looks primarily at psychological trauma and secondary traumatic stress. And the impact of trauma on well-being and outcomes is explored, and the application of research and theory to service delivery is of huge interest. You're also a member of the Psychological Society of Ireland, Silent Voices Advisory Group, which I'd love to know what that is, and the Statutory Parole Board by the Minister for Justice. So thank you so much, Sharon, for being here.
Thanks, Malie, for having me.
Yeah. I suppose, Sharon, I heard you. I've seen you on Twitter for quite a while, and I've heard your name a good bit. I'm really interested, as I'm a psychologist working in primary care in Galway, and I'm just really interested in your work on trauma. But before we go into that, I just thought it'd be interesting to hear what led to your career in psychology and what influenced you along the way.
I suppose, like many people, I think, who get into psychology, we don't really understand what it is. And you have that general idea that you'll be doing something to help people. But I think that a lot of people don't understand really kind of the breadth and depth of the work that psychologists do. I know even, in a lot of psychology undergraduate degrees, only 1/3 of the students go on to become psychologists. But I suppose all my life, my mother's a very social justice orientated person. So I suppose I was raised, so I was raised in a home where it was important to advocate for people who didn't have as much as you did, or who were struggling. So I suppose that would have been kind of the value system I was coming from. So I had different jobs along the way, and I went into psychology. And I suppose with different jobs that I've had along the way, where I'm most interested in the application of psychology is the application of psychology to actually people who need it the most. So I don't know if you've ever heard of the inverse care law. It was coined by a GP in the 1970s in the UK.
Tell me more about that, because our listeners may or may not be aware of that.
Yeah, so the inverse care law was coined, I think it was in 1971, by a GP in the UK, where he looked at healthcare, in particular medical care, and he said, the people who need to access medicine and medical care the most are the people who are less likely to actually receive it. And for me, I think that that transcends into psychology as well. There are groups of people in our community who really, really need to access psychological care, and they really, really struggle to be able to access the services. So people that I'm particularly interested in are very socially excluded young people, people who use drugs, and people experiencing homelessness, and other ethnic minority groups, including the traveling community. So I suppose I've had different jobs with different groups in the community, and now I'm working in a university where I'm doing research, and I'm doing research with those groups with a hope that the research that we do can make some kind of change to policy or practice.
And do you think, is it what you expected? Do you feel that you're able to do what you had set out to do?
I think that making change is something that happens very slowly. Because I think if you look at COVID as an example, actually, in terms of trying to get evidence into practice, in terms of policy is not always driven by evidence. It's often driven by very loud voices or lobby groups. Sometimes there's a peppering of evidence in there. I suppose I was quite naive in thinking that all policy would be driven by evidence, but that doesn't happen. It's much more complicated than that. So sometimes you can be invited to the table and it can feel great to be at the table in terms of policy decision making. But sometimes you might be sitting at the table and they haven't actually given you a plate to eat from.
Oh, really?
Because a lot of it depends on who has the power. And unfortunately, the groups that I'm talking about are not groups of people who have any power. So policy change is something that happens a lot slower than I would like, because I suppose a lot of the things that I do, if you take, for example, drug-related death, almost 2 people in Ireland die every day as a result of drug-related death.
Really? I wouldn't have known that.
There are more people die every year in Ireland from a drug-related death than they do by suicide. And we have significant resources that go into suicide prevention and also into the services that support people who've been bereaved by suicide. We don't have those kind of prevention and intervention and support services available for people who use drugs. So marginalized communities and socially excluded groups do not have power. They very rarely sit at the table. When people who advocate on their behalf do get invited to the table, I think a lot of the time there's no plate there. It can feel tokenistic. I can feel quite negative about that in terms of, I suppose for me, when you meet people who are experiencing such levels of adversity and you collect data, and whether you work in research or whether you work in practice, when you hear the stories from individuals multiple times, and you see how easy it would be to make some changes to make life better, I can find it very frustrating that those changes don't happen. I think there's a study in the impact on mental health in advocacy work, actually, because you start off very excited and very naive and very green, and you get invited to loads of things, and then you see very little change or no change or resistance. And you can really start to have an existential crisis really about what you're doing, and actually about the ethics of what you're doing. So if you take, for example, me as a researcher, I have to ask myself, and I have asked myself a lot this question, is it still ethically appropriate for me to collect data for marginalized groups when I'm hearing the same thing over and over again? Am I now just collecting data for data's sake because that
it's not impacting that directly, perhaps?
Now, positives, because I don't want to be very negative, and it is Monday, is that there are lots of really great grassroots organizations, and that there's huge energy within those, and they make huge changes on an individual level on the ground, you know. Their jobs are made harder by the fact that there are not always national policies to support their work. So I suppose the positives is that there are lots and lots of really great people out there doing great work. The negatives are that policy change happens very, very slowly.
And obviously you're going to keep going. I mean, one of the things that you said, you did a great interview with Blind Boy for his podcast, and you talk about giving psychology away. He spoke about I can't even say it.
Democratizing psychology.
Yeah, exactly. Yeah. Thank you. It's Monday. So yeah, just is this part of what you're talking about there in terms of reaching people who are most in need?
Yeah, so I suppose there's people who really need to access services and they struggle to do so, and that's a separate conversation. But then there's also a group of people who are experiencing a lot of distress, and sometimes they've internalized that and have a very negative internal view of themselves, and they don't always understand that, you know, we are biopsychosocial beings, and that that their social contexts have often impacted on their psychological well-being. So they see themselves as fundamentally bad or flawed. So if you take people experiencing chronic long-term homelessness, who have chronic long-term mental health and perhaps addiction on top of that, many people in that space believe that they are there because they are bad people who made bad choices. And that's often reinforced, of course, by some of the narrative around them. what we do know is that there's very high levels of adversity, both childhood and adult trauma in those populations, which is this is the reason why they are having their difficulties. But they often don't know that.
Yeah.
So one of the things I think about psychology is that we haven't given it away enough, in that, you know, in order to understand more about yourself, you have to go to a psychologist. So if you take, for example, there's a podcast called The Two Norries. I don't know if you've come across it.
I listened to that actually at the weekend, and both of them had been addicted with alcohol or drugs, or so
if I take just one, for example, James is one of the hosts of that. James used to be homeless, and he was a heroin user, overdosed many times and spent lots of time in prison as well. He's now an honours graduate from UCC with both an undergraduate degree and a master's degree, and he's working. So that podcast is people with lived experience who are taking what they've learned and they are giving it back to communities. So that podcast is played in prisons, for example.
Oh, right. Okay.
Yeah, it is played in, it is recommended to a lot of people who go to addiction services. So if you take people from areas of economic deprivation, where there is poor access to education, not a lot of people go on to third level. There's not a level of understanding of, that I have as a psychologist. And one of the things that we see from that podcast, because I get correspondence, I've been on that podcast, and knowing the correspondence that the Two Norries get, is that there are groups of people in communities who do not understand this stuff. And when they get it, when you give it to them in a way that's, digestible, people are saying, oh, so I'm not fundamentally a bad person.
Yeah.
Actually, these 3 or 4 experiences, like poverty, like, a particular type of trauma that they may have experienced, these things actually cause mental health issues.
Yeah. And like what struck me as well, Sharon, was what I can't remember because I don't know them that well, but one of them talked about violence that he had kind of perpetrated, or he had been violent and he felt bad about that, and the way he was then able to contextualize that, and the way you talked about, rather than challenging behavior, you were speaking about adaptive behavior, which I found really interesting. And I think that understanding for him was huge.
Yeah, it's huge. And I actually have a student at the moment who's doing a piece of research actually on the impact of podcasts as a piece of psychoeducation.
Really? Wow.
Yes, because I suppose it struck me after being on I suppose the Blind Boy podcast has a huge reach.
Yeah.
And the Two Norries, their podcast is becoming quite big as well. So it's very interesting, the correspondence that I get from people. So it will be something like, I have always had quite low mood and I've been quite angry all of my life. I always thought that I was just born that way and that maybe I would never be any good. And that's why I'm often suicidal. And I came across this podcast, and what I learned was that there are all of these different things that have impacted the way in which I understand myself and the way in which I understand the world around me. And I now recognize that perhaps living in a home where there was domestic violence as a child is actually the reason why I'm having this low mood and why I'm quite an angry person. And one of the things that I've gotten from this is that actually there's recovery. There's recovery from this, and that I'm not fundamentally a bad person, and that if I do access the right help and address those issues, that I can get better. So like there are a lot of people in our society who do not have the access to the kinds of things that we know, and who when they use our services don't always know how to use them either. So that's that idea of giving psychology away, and as Blind Boy calls it, democratizing psychology. So making what are quite complicated, complex, phenomena that we talk when psychologists are talking, we use a particular language that not everybody else can understand. So it's about taking that and giving that away to people in a way that they can understand, and in a way that lets people know that recovery is possible and that you just need to use some services.
Yeah, absolutely. I mean, it's almost like a reframing of identity, or like moving away from the what's wrong with you to what's happened to you. But also what added for me when you spoke a few weeks ago at that webinar is what's happened to me and how that's influenced my decisions. And like, say, from the likes of compassion focused therapy, which I'm a huge kind of advocate of, we have this lovely sentence that says, no wonder, no wonder, these difficulties have kind of resulted, no wonder. Like, even that idea of one of them, again, I'm sorry, I'm not, I don't know, is it Timmy or James was saying, actually both of them said that had they not used drugs or alcohol, that they may well have killed themselves, that they may well have ended their lives. So that was kind of their, but they didn't see that as a kind of a survival tool, and you explain that to them.
Yeah, so I hear that a lot because I've worked in the addiction services, and a lot of my research now is with people using drugs and people in homelessness. And one of the things that comes up a lot is that if somebody takes away my drugs, what am I left with? I'm left with, quite traumatic memories and feelings that I have no ability to manage, and no access to anybody who can help me manage them. So if you take them away from me, I'm not going to be able to survive. So we often see addiction, for example, as something that's dysfunctional and maladaptive, where I think actually if we were trauma informed, we would reframe it and we would view addiction actually as very adaptive and very functional. Because something that I learned when I worked with young people in addiction services is that all of those substances that people use serve a function.
Yeah.
So if you're in problematic use, things are chaotic and things are out of control, you're not having a good time anymore, this isn't a party situation. Lots of people use drugs recreationally. Most people who use drugs recreationally do not end up in substance dependence. So for the people who do, what's the function? And the function nearly, for a huge amount of people, the function is to dampen down feelings of emotional distress and memories that they cannot manage. But we still have quite a judgmental attitude. We still view it as dysfunctional and maladaptive, but I think that we should start to reframe that.
And that's why, I mean, even people see it more as a choice, because, and, you spoke as well about terms like addict and junkie, which you're really not a fan of. And I suppose as a psychologist working in the services, I'm thinking even of the fact that, if somebody has an issue with alcohol, suddenly you contact the mental health service and they say, oh, well, we're not dealing with that person because they have this issue with alcohol. But then if you go to the alcohol services, sometimes I feel that that they don't delve into maybe the reasons for why somebody's addicted. It's more dealing with the issues right in the here and now. And there's kind of maybe, I don't know, I feel like that the aftercare isn't necessarily there, that somehow there should be a service or something there that, as you said, seeing drug addiction, alcohol addiction, or issues with that as being a mental health issue.
Yeah, so in 2004, Lee McGowan from UCD did a report on dual diagnosis of mental health and addiction, and made a number of recommendations. I think only one of those has been implemented. But a couple of years ago, I did a study on the impact of drug-related death on families and the bereavement process. I currently have a PhD student, Daniel O'Callaghan, who's looking at that in a much wider context. And one of the things that we found is that these families had a loved one who died, and most of their deaths were preventable deaths. And what you had was a period of crisis for a number of years where somebody's in addiction and their mental health issues, particularly if they've experienced trauma, are so great that it is not appropriate for an addiction service to work with them. So they won't. And they'll say, look, your mental health issues are we are not a mental health service. Yeah. So then the person is sent to mental health services and they'll say, look, we cannot deal with you because of your addiction issues, go away. And one thing I want to say is the amount of people who say to me, I met a psychologist or I met a psychiatrist and they told me to come back when I was clean.
Yeah.
Please don't use that word, folks. That's insinuates that somebody's dirty.
Yes.
So it's, go away when you started out your drug and alcohol, come back. And then they would bounce over and back. And then for many of them, their drug-related death was actually suicide. So they would, so overdose is obviously quite high, but some of the people where their death was recorded as a drug-related death in the coroner's court was actually a suicide, where they left a note saying, I cannot get help for the issues that I have. It is causing such distress to my family that everybody would be better off without me. So that's a drug-related suicide.
And that's so sad, because you're in effect saying, as somebody who runs a service, go away until you've gotten rid of the only defense you have, the only, the only way you can manage these thoughts and this horrific, kind of situation you're in, and then come back. It really doesn't make sense.
Well, you see, it doesn't to me, because if you think about eating disorders, for like, there's lots of different types of eating disorders, but one of them is a very problematic relationship with food as a result of a mental health issue that is treated within the mental health services. Alcohol or drug addiction is a very problematic relationship with drugs or alcohol as a result of a mental health issue. Yeah. Why are they not part of the mental health system? I don't know. And people can say, well, you can't do an assessment that gives you a diagnosis if somebody's intoxicated. Why should that be the first thing that you do then? Why don't you work with them until you've reduced their drug and alcohol down to a level that you can do your assessment and your diagnosis? Because what happens is, we've done loads of studies on this, where we've interviewed people who use drugs, we've interviewed people experiencing homelessness on their experiences of trying to access mental health services. And it's not nice. It's a lot of rejection. And these are people who've often experienced a lot of rejection already. There's a very high percentage of former care leavers, a disproportionate amount of former care leavers in homelessness. They've experienced a lot of rejection. And then when they reach out for help, they experience more rejection. And I think that we need to have an honest conversation about the role that we play in that. And I have worked, when I worked with young people in addiction, and I would see them getting rejected from different services. When I would reach out to have a conversation with that service, it was like, look, we just don't do that here, and that's the end of that. So the problem with not even being prepared to have a conversation is that the reality is that people die.
Yes. Yeah.
So we have to at least have a conversation about where this fits and how we can change.
Absolutely, Sharon. And just in terms of trauma, I mean, many of our listeners or people watching this will be aware of what trauma is, and but just what do you feel is the impact of trauma on people's stories? On people generally? I know that's a very big question, and we can drill down a little bit more into it. But what would you say?
I suppose for me is that it is a unique individual experience. That's one of the definitions. So no one person presents in the same way. So you have people at one end of it where their trauma, when they present, they present as what some people would describe as challenging or aggressive. But actually what we've forgotten is psychology 101. Psychology 101, when we learned about what happens in your brain when you're really stressed and there's reduced blood flow to your prefrontal cortex, your thinking brain, your amygdala is heightened, so you're in fight or flight. So when people come to our services and they're angry, they're not angry, they're frightened. Some people have a very sensitive fight or flight response. I've brought young people to different services where when they walk in, somebody at reception, for example, looks them up and down because they're not dressed in a way that they might like. If that young person has experienced rejection in the past, they feel it in their core that they've been treated like this. The minute they walk in the door, their fight or flight response system gets activated. And then when they do meet the psychologist, they come across as oppositional. And I'm sitting there looking at them going, why are you being like this? This isn't how you normally are. And then they're viewed as oppositional, and we don't see what's actually going on. At the other end, then you have people who are just extremely withdrawn. And and sluggish and numb. So how we describe them in services is not motivated.
Mm-hmm. Yeah, not motivated to change.
Yeah, so it's almost, so this is back to the inverse care law.
Yes.
You have people at two ends of the extreme, one who are viewed as very aggressive and one who are viewed as disengaged. And they're likely to be the people who've experienced the most trauma. So if you're lucky enough that you're somewhere balanced in the middle where your distress doesn't come out in either of those ways,
that's really powerful,
then you're going to be able to access the service.
Yeah. So those most in need, because, you know, we're becoming increasingly aware of the impact of trauma on every outcome that we have. Those ones in the middle will be the ones who might access care, but the others that need it the most, as you say, will not, or they'll be seen in a particular way. And the adverse childhood experiences study, I think, you know, I'm hoping most will have heard of that. I've heard you speak about it, and you've also done your own research on the ACEs. Do you want to tell us a bit more about that?
Yeah, so we've collected, so I suppose just to say, in terms of adverse childhood experiences, that there was that very large study that was done by the Centre for Disease Control in the States, Fleety et al. They used a 10-item scale. The problem with that scale is that it places all of the adversity within the family home. It doesn't recognize other adversities like bullying, poverty, exclusion from education, racism, etc. So it's quite limited, but we do know that it's useful for epidemiological research, because there's been so many of those studies done that actually, from a research point of view, it's a real quick, easy way to see how one group of people compares with another. So in terms of but there are 16 or 17 different adverse childhood experiences scales out there. The World Health Organization has its own one, and it includes things like racism. But yes, I've used the 10-item one in research. I've used it with adults in residential addiction service, people experiencing homelessness. We've used it with women in the probation services, and young people involved in the criminal justice system, and professionals working in frontline services. Mm-hmm. So I have a fairly good kind of feel for kind of the level of those 10-item issues within different populations. So, you know, if you take, for example, young people involved in the criminal justice system, in the general population, about 12% of us have 4 or more ACEs. In children who are involved in the criminal justice system, it's about 63%. Wow. Have 4 or more ACEs. Yeah. About 80% have experienced the loss of a parent in childhood. Really? Yes. Really? Yeah. In women who are involved in the criminal justice system, in probation services, you know, they're anywhere between 2.5 to 6 times more likely to have way more ACEs than the general population. They're also more likely to have experienced domestic violence as a child, intimate partner violence as an adult, homelessness as a child, and homelessness as an adult. Homelessness in itself is a trauma. Yes. So look, that's where it comes back to what we were talking about at the start, Malie, is I have all of this data. Mm-hmm. I don't want to collect any more, because, you know, I can keep going. Really? Is that you don't want to collect anymore because of that issue? It's because of what else do I need to tell people? What else do I need to tell people? This is the data. These are the groups who are experiencing lots of challenges. And we also not only have their ACEs scores, we also have done qualitative interviews where they tell us about their experiences of services and what they actually want and what they actually need. So now is the time actually to start implementing these things into policy and practice. Yeah. So, and that, I mean, on a grander level, that sounds like I'm hoping that things will, I don't know, or the politicians or governments, or, you know, that policies will be made in a trauma-informed way, as they are, say, more so in other countries like Scotland, where they've taken that on, you know, the research. But even on, like, say, I'm asking you, I'm a psychologist in primary care, how can an organization become more trauma informed? I have some ideas from what you've said, but, you know, how can we
become, because we had the resilience film, and we were airing that film around Galway, and I was kind of facilitating with Mairead Loftus some of the, we were going to CAMs and to nurses and things, showing them the film and talking about how we could facilitate more trauma-informed organizations. Psychologists have been working in a trauma, we've known about trauma all along for the last however many years. We know but I kind of feel like on a practical level, we don't, in terms of, oh yeah, three failures to attend appointments and you're out. Write a letter to somebody who mightn't even be able to read, so like even those things, I feel like, we don't know it all. And I kind of, as a psychologist, what can we do to kind of help become more trauma informed or more open to all different types of clients?
For psychologists, I'm did psychology, I studied in university, so I'm well aware of what the risk and resilience factors in development are. So any psychologist who says we know this stuff and we know it for years is right. But actually it's not translating on the ground. Because when with our research, I can tell you that the view from the people who need it the most, the people who need this the most traumatized, are not very positive about the experiences of attending services for the types of issues that you've raised there, getting an unpleasant letter in the post saying you failed to attend 3 appointments without understanding why that person failed to attend 3 appointments. I'm going to give you an example. I have a daughter who has a couple of medical conditions, and she recently got an appointment for her yearly checkup with a consultant, and the appointment time was for 2:30. And I teach from 2 to 4. And I have another child who would be coming out of primary school at 2:30. So that meant that my husband would have to be in 2 places at one time. He'd have to be in the hospital with the child, and you can't bring anybody with you now because of COVID. And he'd also have to collect a child from school, and you can't ask anybody to collect the other child from school. So for the first time ever, I needed to change the appointment. I rang every single day for 7 days. And I never got to speak to anybody that could help me change the appointment. I left several messages and they were not returned. So on that particular day, I also had to go to Dublin on the train, and I had to be at the train at 5 o'clock. So I arrived at the hospital, and I had my letter which said, please dial this mobile number to let us know that you're in the car park and somebody will come out and get you. I rang that number 17 times and nobody answered it. So this is about 6 weeks ago. The 8-year-old then is in the car saying, Mom, I need to go for a wee, I need to go for a wee. So then I Googled the main number of the hospital, got through to the main, explained my situation. They put me through to the unit where I was going to go, said, look, I'm in the car park. I've rang this number 17 times and nobody has answered. And they said, oh, that number does not work anymore.
Oh my God.
So you can just come in. So I did. I went in, and then I went in and I realized that there were 10 other people there, and we all had an appointment for the same time. So I had no idea how long we were going to wait. And I'm thinking about the fact that I need to get this child here and then bring her home, collect my suitcase, get on the train and get to Dublin. So I was stressed and irritated, but because I'm a psychologist, I was aware of that. I could feel it in my body. I could feel the physiological response. So I was grounding myself, and I made a conscious decision not to speak at all, because I thought if I speak, I'm going to absolutely lose it. Now, I'm a psychologist. I have a permanent job. I have a home. I have a partner. I have resources. What about the women who are living in homelessness with children, who only barely have enough money for the bus, and who don't have the resources around them to help them with other children? They sometimes, if I had walked away from that car park that day, I would have been put down as a did not attend. When the truth was, I had to attend. I tried everything not to. There were plenty of people who will try really hard to attend. They will also try really hard to communicate with you about why they can't attend, but we don't listen. And then they'll be put down as a did not attend or not motivated. I remember working with a young person once, and he had been excluded from another service because he kept failing to turn up for his appointments. And we gave him an appointment and he didn't turn up. And we had hired this woman because we recognized the young people that we worked with had experienced trauma. A lot of them had experienced trauma. They had multiple difficulties. There were massive hurdles that prevented them from attending our appointments. So we hired somebody specifically, and their job was to understand what was needed to get this person into their appointment. So this young man who had been referred to us for drug and alcohol issue had such bad social anxiety, and that's why he was taking drugs and alcohol, because that's what he needed in order to survive outside of the house. He couldn't get on the bus.
All right.
He couldn't get on the bus to come to us, but he was an adolescent, and he found that really difficult to explain to us that he couldn't get on the bus because he didn't even understand it himself.
Yeah.
So when she was working with him to try and figure out how do you think you'd come to the appointment, he said, I can't get there. And she said, why not? And he said, I'd have to get the bus. And then he'd have this big story about the bus and the times, and that it became, so complicated in his head that when you stripped it back, what the actual problem was his anxiety was so bad he couldn't bring himself to get on the bus in the first place. Mm-hmm. So then we paid for a taxi to collect him.
Right. Okay. So it's actually taking the time to even like, if we're to take one recommendation from today, it's taking the time to figure out what is people's difficulty in engaging with services and really exploring that. And I think, what happens I'm just thinking as a primary care psychologist, when we get a DNA, sometimes we're like, phew, because I've so many other people to see and so many other people to open. You see that? So I think it's hugely important to do that. I suppose from a practical point of view, I'm kind of wondering, we need to kind of direct resources into being able to offer that, because I'm just thinking from a practical point of view, when you've that many people on a list and that many people to get through, and you don't have secretarial support a lot of the time, or an assistant psychologist, it's hard to actually get there. And I'm not trying to put a hurdle in front of what you're saying, but right. I'm just kind of talking about the reality of working in primary care psychology in Ireland,
Yeah, well, because ye are under-resourced, and something has to be done about that, because I understand when you're there and you've got 300 things to do, and somebody is due at 11 o'clock and then 11:15 comes and it becomes clear they're not going to turn up. There's now I can get 5 things off my to-do list. So it's not like you're sitting there going, "Woo, nobody turned up. I'm going to sit here and watch
oh God, no,
for an hour." Yeah, I understand.
But as you become more experienced, though, I think, especially when I've met somebody or had any contact with them at all, I would just pick up the phone and say, is everything okay? Or now I use my phone a lot more, like my work phone, so they can text me and say, I'm sitting on the bus, I'll be there in 15. With teenagers, I'm quite open-ended about when they come. Just come when you can, after you finish school or after you finish college. So those things can help. But I think definitely what you say there about we need to focus on getting people to access the service, the most needy. And I totally agree that the most needy are not accessing our service.
Because to be honest, if you've got, mental health issues that require you to attend a psychologist, the fact that you're able to turn up means that you're doing really well. Actually.
Yeah, that's true.
There's some level of functioning there. There are people who have severe chronic mental health issues who don't turn up because there's no functioning. And it's not because they don't want to turn up or they're difficult, or it's a feature of their experience. And sometimes there's this belief, I think, that if you build it, they will come. And for example, in New Zealand, they had built this primary care centre for the Indigenous community, and very, very poor attendance. Something like 20% of appointments were attended. And they thought, well, we're after investing in this building and these staff, and why aren't they coming? And then they went out and they spoke to the community. So somebody was getting an appointment for 9 o'clock in the morning and they couldn't become because they had childcare issues or whatever. And then they started saying, okay, so effectively we've designed this service that does not meet the community's needs. So they went back and they went out into the community and said, what do you actually need? And they implemented that into the service, and then it went from 20% attendance up to 60% attendance within 6 weeks.
That's incredible.
Because as well as that, like if you were working as a psychologist, you know, presumably you've had a life that has meant that you've had access to resources too. It can be very difficult for us to even begin to imagine.
Yeah, I think
the
you're right. Yeah.
Actual, like, you know, when you say, like, there will be clients or patients, when you say about I've all of these things to do and I don't have time, there will be people who will think that when somebody doesn't turn up that you've nothing else to do and that you've a great life. So there are people at the other end who don't understand what you do. But equally, at our end, we don't understand the challenges for everybody who's coming to us either.
No, I don't think we do. I don't think we do.
What I'd love to see is obviously more psychologists, because I think that actually a psychologist, for me, in an ideal world, you shouldn't have caseload of more than 25. Mm. If you want to actually do meaningful work, you shouldn't have more than 25 on a caseload.
And not 80 on a waiting list.
That's ridiculous. So the other thing I would like to see is key workers. Yeah. So if you look in homelessness, for people who are very, you know, who are really struggling the most, they cannot remember appointments, you know, the things that lots of us take for granted, they just don't remember. So they have key workers, and the key workers' job is to help link them to all of the things that they need and to keep on top of it and say, look, Sharon, you have an appointment tomorrow at 11 o'clock with Malie. And then the key worker might say, so, you know, actually, I know that Sharon really struggles in the morning. I'm going to ring Malie and see, can I get an afternoon appointment? Because Sharon's not going to be able to do that for herself. So key workers, we did a study actually on health and homelessness in Cork City. And what we found was people who were experiencing homelessness who didn't have key workers had significantly worse health outcomes.
Really?
Yeah, like even things like they were statistically less likely to have something as basic as a medical card.
It sounds to me almost like the one good person. You know, sometimes the one good person is the one who emotionally supports you, but the one good person is also the one who gives you the practical support or enables you to access these resources that you need.
And you see, and we have key workers in lots of different types of so addiction, homelessness, for example. You don't have key workers in primary care. It's better if you had your own key workers, because if I'm a key worker and I'm working in homelessness and I'm advocating for my client in homelessness, I don't understand Malie's job and I don't understand the pressures that you're under. So we're much more likely to probably clash, maybe because I'll be like, Malie's not flexible or she's not doing this. Whereas if you had a key worker in your building, they would be advocating for the clients while also understanding what actually happens in your building. So they'd say, Sharon, Malie would love to give you an appointment for 3 o'clock on a Thursday, but that's not going to happen because, and then if the client trusts the key worker, they're much more likely to trust you too, because that they're the person who's the boots on the ground helping them. So if they say, Malie's a great person, I want you to come in at 2 o'clock on Tuesday, they'll be like, okay, because they're, you know, if you think about the caseload that you have and the paperwork and the admin and all that stuff that you have, having a key worker who can maintain those relationships, the interpersonal relationships, means that actually people develop then an attachment or a relationship with the organization.
Yes, yeah.
So once they've developed an attachment or a relationship with the organization, that's everybody within it, you know?
Yeah, absolutely. No, I mean, that's such food for thought, Sharon. And I mean, there's so much more we could talk about, but we're going to leave it there. And I just want to thank you so much. Like, you know, when I asked you to, you know, when Padraig Collins and I were discussing it, he kind of heads this journal. And I was like, I'd love to get Sharon Lambert, but like, I'm sure she'll be too busy or whatever. You know, it was just like that. You were my number one wish. And then when you got back to me on Twitter and said, okay, I was like, oh my God, cool. You know, and I just wanted to say thank you so much, because like, I know you're in the middle of your lunch break right now, but you're doing exactly what, you know, even though, like, I'm just so glad your light has not been extinguished by the kind of the issues that you deal with in terms of maybe not bringing stuff into policy, that your light is still very much there, and that people listening, like you'll have psychologists and other professionals listening to this, and hopefully it will kind of, you know, kind of flick a light switch in their mind about, oh, well, maybe I should ring the person and figure out, or get an assistant psychologist to ring them, and maybe there's something we can do as an organization to help with that. So I really thank you so much for agreeing to come on and to share your wisdom, and I really wish you the best with all your work.
Thank you so much for having me, Malie.
And what would you suggest, just finally, Sharon, if anybody wants to find out more about your work? I asked you already in my email, like what kind of podcasts or interviews or things that could they listen to that they could find out a bit more about your work?
Well, so most of my research is up on my research profile page on UCC. So if you just look at Sharon Lambert UCC, I'm very happy if anybody emails me to share my research, because it's that philosophy of giving psychology away, which was coined by George Miller. So you have to live it, you have to give it away. In terms of what do I think? I think people should listen to the two Norries, not my podcast, actually. I think they should listen to the other speakers. So they are people who've experienced a lot of adversity in their lifetime. These are people who have attended your services in the past, if you're a psychologist, and they have not engaged, or they've been perceived to have not engaged, or they've been perceived to be difficult or challenging. This is them at the other side of it now, because they found something that worked for them along the road. So I'd like people to listen to them, and to remember that when you're listening to the likes of James and Timmy, for example, who are the hosts, the first 4 episodes of their podcast are their own personal stories. When they were adolescents, they were very challenging. Timmy was very aggressive, and he was sent to prison for violence. And if you look at him now, he's the kindest, gentlest little angel. You're just mad about him. But so there are teenage boys and teenage girls and adult men and adult women who are coming into your services that are Timmy and James. They're just not further along the road than Timmy and James, but they all have the potential to be. And if you can see Timmy and James and the other contributors on their podcast in the people who are your most challenging, and when you are tired and when you are stressed and when you are working in a system that is so grossly under-resourced, it can be very easy when somebody is really difficult and they don't turn up. You're so tired that there is a relief. So if there's a way of dipping in so that you can go that extra mile, they can be Timmy and James too.
Yes, thank you. That's just a beautiful way to sum that up. Thank you so much, Sharon, and I wish you well with everything. I'm sure we'll be in touch, and thank you for agreeing to do this for all of us.
Thanks, Malie.
All right. Cheers.
You've been listening to the latest podcast from Clinical Psychology Today. We hope you enjoyed it. To receive the journal twice a year into your email inbox free of charge, just email us at clinicalpsychologytoday@gmail.com. We'd also love to hear from anyone interested in being part of our editorial network, which helps shape the direction of the journal. Or indeed, if you're interested in doing a review for Clinical Psychology Today. If you're interested in being a reviewer, just drop us a line. Let us know what kind of topics interest you. And if we get a submission along that line, we'll drop it into you, no more than 1 in a year, along with some very straightforward guidance about carrying out a review. In that way, you can be part of a broad community of individuals whose generosity has helped ensure that the journal is the success that it is as an entirely voluntary endeavour. Thanking you, and goodbye.